Many of us have had close encounters with the emotional extremes of mood disorders. Now, mood disorders are psychological disorders that are characterized by emotional extremes. So during the course of this lesson, I hope that we can learn the following. What are the main mood disorders? Why do people attempt suicide, and why do some people injure themselves? How do mood disorders develop, and what roles do biology, thinking, and social behavior play? What patterns of thinking, perceiving, and feeling characterized schizophrenia? And what are the three major eating disorders? So let's start with mood disorders. Mood disorders appear in two principal forms. We have Major Depressive Disorder. It's a persistent state of hopelessness and depression. And then we have Bipolar Disorder. It's an alternation between depression and overexcited hyperactivity. So first, let's talk a little bit more about Major Depressive Disorder. So to feel bad in reaction to a very sad event is to be in touch with reality. In such times, depression is kind of like a car's oil light, a signal that warns us to stop and take appropriate measures. Depression makes sense from an evolutionary perspective. As one social psychologist warned, if someone offered you a pill that would make you permanently happy, you would be well advised to run fast and run far. Emotion is a compass that tells us what to do, and a compass that is perpetually stuck on north is worthless. So biologically speaking, life's purpose is survival and reproduction, not happiness. Just as coughing, vomiting, and various forms of pain protect our bodies from danger, from dangerous toxins to get rid of them out of our body, so depression protects us from dangerous thoughts and feelings. It slows us down and gives us time to think hard and consider our options. It diffuses aggression, it cuts back on risk-taking, and it focuses our mind. Sometimes, however, depression becomes seriously maladaptive. So, a maladaptive is bad. We cannot function with this kind of depression. Sometimes it's something that is overwhelming. So how do we recognize the difference between a normal blue mood and an abnormal depression? So we have a few ways that we can figure this out. Okay, so joy, contentment, and sadness and despair are different points on the continuum, and they may be found at any given moment. The difference between blue mood and a bad news is that major depressive disorder is like the difference between gasping for breath after a hard run and having chronic asthma. Major depressive disorders occur when signs of depression last at least 2 or more weeks and are not caused by drugs or a medical condition. These signs include lethargy or lack of energy, a feeling of worthlessness, a loss of interest in family and friends, and major depression, and the combined with anguish and grief, with exhaustion you feel after pulling an all-nighter. All of those things combined will create major depressive disorder. And they have to have the mood disorder of major depressive disorder. They have to, in the absence of drugs or a medical condition, you have to have 5 or more symptoms, at least one of which must be either the depressed mood or loss of interest or pleasure. Okay, so one of the 5 following symptoms have to be present for it to be considered a major depressive disorder. Or, I'm sorry, 5 of the following symptoms have to be considered to be present. So you have a depressed mood most of the day, loss of interest or pleasure in activities for most of the day, significant weight loss or gain, insomnia, so not being able to sleep or sleeping too much, physical agitation or lethargy, like no reaction to things or you overreact to things, you're easily annoyed or agitated, fatigue or loss of energy, feeling worthless or excessive inappropriate guilt, problems thinking, concentrating, or making decisions, or reoccurrent thought of death and suicide. These are all very serious. And especially that last one, if you know of somebody that has recurring thoughts of death and suicide, they certainly need help right away. So let's talk about bipolar disorder now. So with bipolar disorder, people bounce from one emotional extreme to another, week to week and not day to day or moment to moment. And so when a depressive episode ends, an intensely happy, over-talkative, wildly energetic, and extremely optimistic state called mania follows just before the long, elated mood either returns to normal or plunges again into depression. Okay, so if depression is living in slow motion, mania is fast forward. During mania, people feel little need to sleep and they're easily irritated and show fewer sexual inhibitions. They're feeling extreme optimism, self-esteem, and they find advice annoying, yet they need protection from their poor judgment, which may lead to reckless spending or unsafe sex. So this is a mood disorder when we have very extremes. We have either really hopeless states, depressed states, or else we are in that manic, hyperactive, wildly optimistic state. Each year, nearly 1 million despairing people worldwide will elect a permanent solution for what might have been a temporary problem. The risk of suicide is at least 5 times greater for those who have been depressed than for the general population. People rarely, however, elect suicide. While in the depths of depression, when energy and initiative are lacking, the risk really increases when they begin to rebound and become more capable of following through. Suicide is not necessarily an act of hostility or revenge. Elderly people sometimes choose death as an alternative to current or future suffering. People of all ages may view suicide as a way of switching off unendurable pain and relieving a perceived burden on family members. People desire death when 2 fundamental needs are frustrated to the point of extinction, noted one psychologist: the need to belong or connect with others and the need to feel effective with or to influence others. Suicide urges typically increase when people feel connected with others and a burden to them. Now, when they feel defeated and trapped by a situation they feel they cannot escape, thus suicide rates increase a bit during economic recessions, just because it seems hopeless, something that they can't cope with or deal with. So why do people hurt themselves? Because not only is suicide an issue, but we also have what's called NSSI, which is actually called non-suicidal self-injury. So we need to understand why people hurt themselves. Those who do so tend to be less able to tolerate emotional distress. They're often extremely self-critical with poor communication and problem-solving skills. It's really common for these people to be cutting their arms in places or their legs. Oftentimes it's in places where people can't see. So students or people involved in cutting will probably wear clothing to hide it so that sometimes they don't want to draw attention to it. So they may engage in non-suicidal self-injury if they try to gain relief from intense negative thoughts and emotional pain. They also do it as a form of asking for help or gaining attention. It's a call for help sometimes. Also, it kind of serves as a way for them to feel relief from guilt. This is like a punishing themselves oftentimes. And also to get others to change their negative behavior. For example, if they have a bully or too many people criticizing them, hopefully this will draw attention to that. And sometimes in cases it actually also is connected with teens, especially trying to fit into a peer group. So, does non-suicidal injury lead to suicide? So, usually not. Those who engage in NSSI or non-suicidal self-injury are typically suicide gestures, not suicide attempts. Suicide gestures engage in non-suicidal self-injury as a desperate form but not life-threatening form of communication, or when they are feeling overwhelmed. But the risk factor for future suicide attempts actually are going to go up. If people do not find help, their non-suicidal behavior may escalate to suicidal thoughts and finally to suicide attempts. The point is to remember that if a friend talks suicide to you or engages in non-suicidal self-injury, it's important to listen and to direct the person to proper professional help. Your friend may at least be sending a signal or feeling desperate beyond hope. So, if people do not find help, their non-suicidal behavior may escalate to suicidal thoughts and finally to suicide attempts. So, we need to try to understand mood disorders. How do mood disorders develop, and what roles do biology, thinking, and social behavior play in mood disorders? Say from thousands of studies of cases of causes, treatments, and prevention of mood disorders, researchers have pulled out some common threads. Now here are some findings that any theory of depression must explain. So first off, behaviors and thoughts change with depression. People trapped in depression moods are inactive and they feel unmotivated. They're sensitive to negative happenings. Okay, so they recall negative information and they expect negative outcomes. So they become quite pessimistic, I guess. Depression is widespread. Depression is found worldwide, and so does schizophrenia also as well, that we'll talk about in a minute. This is going to suggest that depression causes too must be also common. The causes of depression must be common as well, since it's worldwide. Women's risk of major depression is nearly double of men's. In 2009, when Gallup pollsters asked more than 250,000 Americans if they had ever been diagnosed with depression, 13% and 22% of women said yes. So, when Gallup asked Americans if they experienced sadness during a lot of the day yesterday, 17% of men said yes, and 28% of women answered yes. So, definitely a gender gap in depression. Also, most major depressive episodes end on their own. Although therapy often speeds recovery, most people suffering major depression eventually return to normal even without professional help, which is good news. Stressful events sometimes precede depression. A family member's death, a job loss, a marital crisis, or physical assault increases one's risk of depression. And finally, with each new generation, depression is striking earlier in life, now often in the late teens and affecting more people. Okay, so this is kind of scary. The increased risk among young adults appears partly real, but it may also reflect an increased reporting due to cultural differences. Today's young people are more willing to talk openly about their depression, where in the past, not so much. So it was just kind of taboo to talk about things like depression. Okay, so we need to talk about the biological influence of mood disorders. First off, we have depression is a whole body disorder. We need to remember that it may disrupt our sleep, our appetite, our energy, concentration. It involves genetic predispositions and biochemical imbalances, as well as negative thoughts and gloomy mood. So we have known for a long time that mood disorders run in families. The risk of major depressive disorder and bipolar disorder increases if you have a parent or a brother or sister with the disorder. If one identical twin is diagnosed with major depressive disorder, the chances are 1 in 2 that sometime the other twin will be too. If one identical twin has bipolar disorder, the chances are 7 in 10 that the other twin will at some point be diagnosed. Similarly, among fraternal twins, the correspondent odds are just 2 in 10. So what we learned from identical twins, because remember they're identical genetically, is that genes really matter. This is something that can be something it's passed on through the genetic pool. So with chromosomes, some 3 genes indicate in separate British and American studies that they may open the door to more effective drug therapy as well. Genetics really do matter. Also, the brain. Scanning devices open a window on the brain's activity during depression and manic states. So during the depression, the brain activity slows down. When we are depressed, we have a depressed brain. During mania, it increases. The left frontal lobe, which is active during positive emotions, is less active during depression or during our depressed times. Okay, so all of these things, genes, it runs in the family, and of course we have our brain and all of our hormones and neurotransmitters, all those things that play into how our moods develop. Okay, so let's talk a little bit about the psychological and social influence. Biological influences contribute to the depression, but in the nature-nurture, dance, thinking and acting play an important role as well. Thinking certainly does matter. The social cognitive perspective explores people's assumptions and expectations and how they influence and perceive. Depressed people see life through dark glasses. They have intensely negative views of themselves and their situation and their future. So we need to be careful that we do not think those negative thoughts. So also we have life experiences. Certain times we experience things and it makes a big difference. The kinds of things that we go through in our life. We also have negative thoughts and negative moods interact, just like I said. Self-defeating beliefs may arise from learned helplessness. That's something that we always try to explain why something happens. That's just human nature. And if we explain it in a negative way, then we're going to have that negative mood that's associated with it as well. Also, depression is a vicious cycle. Depression, social withdrawal, and rejection, they just kind of all feed off of one another. It's also, it's brought on by oftentimes stress or unfortunate events, but if we allow ourselves to get caught up in depression, it will just feed on each other. It's like a snake biting its tail. So here's the cycle of depression. By changing the way depressed people process events, psychiatrists describe they can prescribe medication or try to alter biological roots of persistently depressed moods. But sometimes in this cycle of depression, we really need to find an appropriate place to break the cycle. We have the stressful experience happens. Let's say we have a breakup with a boyfriend or something like that. So what we could do is the negative explanatory style, such as, oh, it's all my fault. Without my partner, I'm nothing, and it was all my fault. So when saying that and interpreting it that way, and that I'm never going to have anybody, and my life is not going to be nearly as fun without this person, then we're going to naturally drop into that depressed state of mind, that depressed mood. So when we are in that depressed mood, now we also show that in our behavior and in our other thinking. It's all going to be more depressed. If you've ever been around somebody that's depressed or cranky all the time, you know that they're not real fun to be around. And so when you're in that behavioral change from depression, people might not want to be around you. They might think that you're mad all the time or stuck up or whatever. But what happens as a result is you go back to one. Nobody likes me. Nobody wants to hang around me because you're depressed all the time and you're giving those bad vibes or negative signals to people. So it's a cycle that just will keep feeding on itself if it's not broken. So this graph here illustrates the vicious cycle of depressed thinking. Cognitive therapists will try to break this cycle by in somewhere injecting in their therapy or different ways of thinking and perhaps even medication if needed. Okay, so let's start into schizophrenia. Schizophrenia is a psychological disorder characterized by delusions, hallucinations, disorganized speech, and or a diminished, inappropriate emotional expression. So there are negative and positive symptoms with schizophrenia. Negative, we have the absence of normal behavior. Usually the negative symptoms appear months or years before the positive symptoms. We have the positive symptoms. They are an increase in abnormal behavior, like things that are added to, things like seeing people that aren't really there and things like this. This is abnormal stuff, okay? All right, so let's move on. All right, so positive symptoms. They may have hallucinations or talk in a disorganized and diluted way. They may laugh or cry or lash out in rage at inappropriate times. Their symptoms are positive in the sense that inappropriate behaviors are present. These are inappropriate things are present, is why these are considered, positive. So the hallucinations, delusions, thought disorders, and movement disorders. So just so you know what delusions and hallucinations are. Delusions are false beliefs, often of persecution or even grandeur. Okay, so, when we talk about it, imagine trying to communicate with a young woman whose thoughts spill out in no logical order. Okay, she tries to, she's not talking to anyone in particular. This morning when I was at the hillside, I was making a movie. I was surrounded by movie stars. I'm Mary Poppins in this room painted blue to get me upset. My grandmother died 4 weeks after my 18th birthday. All this goes on. Does that sentence make sense, or that passage make sense to you? That is a conversation from a schizophrenic. So as this strange speech illustrates, the thinking of a person with schizophrenia is fragmented and often distorted by false beliefs called delusions. So Maxine believed that she was Mary Poppins. People with paranoid tendency often believe they're being threatened or pursued. Someone's chasing me. Someone's trying to kill me. So delusions are going to be false beliefs, and hallucinations are false perceptions. People with schizophrenia sometimes see, feel, taste, or smell things that exist only in their minds. Most often, however, the hallucinations are sounds, often voices that are made insulting remarks or giving them orders. The voices may tell the person that he or she is bad or that she must burn herself with a cigarette lighter. Imagine your own reaction if a dream broke into your waking consciousness, making it hard for you to separate your experience from your imagination. It's a terrifying thought. So the expressed emotions of schizophrenia are often utterly inappropriate, split off from reality. Okay, so we have the negative symptoms as well. So oftentimes with schizophrenia, they lapse into emotionless, flat affect, a zombie-like state of no apparent feeling. People with schizophrenia have difficulty reading other people's faces and emotions. They have inappropriate motor behavior takes many forms. Some patients perform senseless, compulsive acts such as continually rocking back and forth or rubbing an arm. Others might remain motionless for hours and then become agitated. So it's really the negative things, or the things that are absent, that should be in, that you don't find in a healthy person. So the loss of interest in everyday activities, the lack of motivation or personal hygiene, social withdrawal, appearing lack of emotion. So this first slide, you're going to see someone that is an observer of schizophrenia. Okay, so this is what they see in the schizophrenic person.
How are you? Did you find everything you needed? sir? Sir, paper or plastic? Sir, are you okay?
So you'll notice that he was looking kind of disoriented, nervous, looking around all the time, a little bit jittery, agitated, didn't really talk to anybody. So this is what he is experiencing. This is from the standpoint of the person that is suffering from schizophrenia.
Hi, how are you? It's all right, no, it's okay. Okay. Do you realize you're sick? Did you find everything you needed? You see all these people here? You're going to make them sick.
That's way better.
What's he doing? Hi there. Hi. He knows he's not doing that. Yeah, I'm in the supermarket. He'll only get us some. Did he really? He did. Loser! Okay, total is $14.85. Paper or plastic, sir? Trash. Trash. None of this will help you, sir. Paper or plastic? You're sick. You know that? You're just sick. Sick.
Okay, so his experience was definitely pretty frightening. Okay, so there's two different types of schizophrenia that we need to talk about very quickly. We have, for some, schizophrenia it appears suddenly and seemingly as a reaction to stress, and recovery in this case is much more likely. That would be the acute schizophrenia. It's going to develop very rapidly and because of some sort of traumatic event or stress. However, the chronic schizophrenia, for some people, it develops gradually. It's emerging from a long history of social inadequacy. And it usually kind of starts manifesting itself or begins in adolescence. This may explain why people predisposed to schizophrenia are found in the lower socioeconomic levels of homelessness. When schizophrenia is a slow developing process, recovery is going to be doubtful. Social withdrawal, negative symptoms is common among those with chronic schizophrenia. Okay, so of the things that cause schizophrenia, what causes schizophrenia? Scientists have known the strange behavior can have strange chemical causes, and that's one of the things that we've found with schizophrenia. Researchers examined schizophrenic patients' brains after death, and they found that an excess number of dopamine receptors are found. This means perhaps a high level of dopamine could intensify brain signals, creating positive symptoms just like the hallucinations and the paranoia and things. Okay, and so that's one of the things that we think about with schizophrenia. We also have this abnormal brain activity and anatomy. Brain scans have shown that the abnormal brain activity and brain structures accompany schizophrenia. Some patients have abnormally low activity in the brain frontal lobes, which are critical for reasoning, planning, and problem solving. So in schizophrenia, areas of the brain, it becomes enlarged and they fill with fluid. Cerebral tissue is also shrinking. People with schizophrenia are losing brain tissue at a more rapid rate than healthy people. So the greater the shrinkage, the more severe the disorder is what we're thinking. Also, prenatal environment can actually have an effect. The brain abnormalities that are found in people with schizophrenia, some researchers blame low birth weight or lack of oxygen during delivery for this. So that's one of the things that they are thinking and considering. Also, prenatal viral infections can contribute to the development of schizophrenia, and also we have genetic issues as well. Okay, so people are more vulnerable because they have inherited a predisposition to this in this disorder. For most people, the odds of being diagnosed with schizophrenia are nearly 1 in 100. For those who have a sibling or a parent with schizophrenia, the odds increase to 1 in 10. And if the affected sibling is an identical twin, the odds are close to 5 in 10. Those odds are unchanged even if the twins are raised apart. So genetics are really important in schizophrenia. So now we are going to switch gears for a minute, and we're going to be talking about eating disorders. So our bodies are naturally predisposed to maintain a steady weight for storing energy, reserving and energy in case food becomes unavailable. But psychological influences can overwhelm biological wisdom. Nowhere is this more painfully clear than eating disorders. First, let's talk about anorexia nervosa. People, usually female adolescents in anorexia, they starve themselves. And anorexia often begins as an attempt to lose weight, but then the dieting doesn't end. Even when far below normal weight, the self-starved person feels fat. They feel being fat, and they focus obsessively on losing weight. Sometimes exercising excessively as well. At some point in their lifetime, 0.6% of Americans meet the criteria for anorexia nervosa. Many people with the disorder come from competitive, high-achieving families. They tend to have low self-esteem, to set impossible standards, and to fret about falling short of expectations. We also have bulimia nervosa. So this is an eating disorder in which a person alternates with food binges and alternate between vomiting and laxative use, fasting, and excessive exercise. Unlike anorexia, bulimia is marked by weight shifts within or above normal range, making this disorder easier to hide. Binge purge eaters are preoccupied with food, especially sweet, high-fat foods, and obsessed with their weight and appearance. They experience bouts of guilt, depression, and anxiety especially during the following binges. About 1% of Americans, mostly women in their late teens or early 20s, have had bulimia. And the new one that's been added to the books is binge-eating disorder. In binge-eating disorder, significant binge eating, which is eating lots of food, is followed by remorse. But people with this disorder do not purge, fast, or exercise excessively after their food binges, and so they may be overweight. At some point during their lifetime, 2.8% of Americans have had binge-eating disorder. So let's talk about the possible influences to these disorders. Bigger does not seem better in Western cultures. A lot of cultures, the environment matter. So we have all of these things that matter. You can inherit a certain weight or a certain body type, and also you can inherit also a mental predisposition for anxiety and eating disorders. So that's something that you inherit. Also the culture. Bigger does not seem better in Western cultures. In the Polynesian culture, bigger is considered beautiful. Where the rise in eating disorders over the last 50 years has coincided with the dramatic increase in women having poor body image. Part of the pressure on women seems to stem from images of unnaturally thin models and celebrities. So viewing such images, women, especially those who can't resist comparing their bodies with others, often feel ashamed and depressed and dissatisfied with their own bodies. In one study, researchers tested media influences by giving some adolescent girls, but not others, a 15-month subscription to a teen fashion magazine. Vulnerable magazine readers, or girls who felt dissatisfied, idealized thinness, and lacked social support, showed increased body dissatisfaction and eating disorder tendencies. But there is just much more to body dissatisfaction and anorexia than media effects. Pure influences like teasing also matter. So do wealth, increased marriage age, and especially competition for available mates. These are all social influences that also have a big influence on eating disorders. So we have hereditary, cultural, media, and social influences.